Welcome to This Explainer. Today, we're stepping right onto the surgical floor for a highly dynamic clinical round session, diving deep into the diagnosis and management of small bowel pathologies. I'm honestly thrilled to guide you through this, mostly because treating the small bowel requires this perfect blend of anatomical knowledge, surgical intuition, and a really solid grasp of the underlying cellular mechanisms. We're going to break down some high-yield clinical scenarios directly from the source literature to crystallize exactly what you need to know.
Here's our patient chart for today's rounds. We've got 5 main clinical areas to conquer: Crohn's disease pathology, fistulas and obstructions, Meckel's diverticulum, short bowel syndrome, and small bowel tumors. Let's jump right in. Section 1, Crohn's disease pathology. Let's take a look at the distinct architectural changes happening in the gut. All right, I want you to put on your attending physician hat for a second. You've got a 45-year-old male presenting with recurrent episodes of small bowel obstruction. His follow-through imaging reveals multiple classic skip lesions, meaning you have areas of really sharp, inflamed bowel separated by totally normal-looking mucosa. Plus, there's a severe narrowing in the terminal ileum that creates a radiographic string sign. Based on that exact presentation, what is your diagnosis? If you locked in Crohn's disease, you absolutely nailed it. That string sign, sometimes called the string sign of Cantor, is the radiologic hallmark of intense chronic narrowing in the gastrointestinal tract. What you're actually seeing on that film is a severely strictured fibrotic lumen which pops up most often right there in the terminal ileum. But to really grasp why this happens, we have to zoom into the cellular level. This comparison really gets to the why behind Crohn's complications. Unlike ulcerative colitis, which is strictly a mucosal and submucosal process, Crohn's disease is all about transmural inflammation. And transmural means it literally cuts through every single structural layer of the bowel wall: the mucosa, submucosa, muscularis propria, all the way out to the serosa. That is exactly why you get those deep fissuring ulcers and that highly classic cobblestone appearance on an enteroscopy. This transmural nature is the root cause of the mechanical nightmares like strictures, abscesses, and complex fistulas that these patients have to deal with. Moving on to Section 2, fistulas and obstructions. Let's tackle some of the trickiest mechanical issues in the gut. Okay, you get paged to see a 34-year-old female who recently had an open appendectomy. Now, she's developing a high-output enterocutaneous fistula. We're talking massive losses here, draining about 800 milliliters a day of succus entericus right through her surgical wound. High-output fistulas like this cause incredibly rapid, life-threatening fluid depletion. So as the clinician, what is your absolute first life-saving stabilization step? The crucial takeaway here is you must resist the urge to operate. Her inflamed, what we call hostile abdomen, is full of dense adhesions, which makes early reoperation strictly contraindicated. A safe bowel dissection is basically impossible right now. Instead, your initial phase is entirely medical. Aggressively resuscitate her fluids, enforce absolute bowel rest, protect her skin, and initiate TPN. You have to keep her nourished while giving that localized inflammation weeks to cool down. Now, say you're managing this patient conservatively, and the fistula just simply will not close. You've got to think about the friend mnemonic. This outlines the classic local factors that stop natural healing dead in its tracks. Is there a foreign body, radiation damage, an infection or abscess? Has the tract epithelialized, where the skin meets the mucosa to form a permanent pipe? Is there a neoplasm, or maybe a distal bowel obstruction, forcing fluid out the path of least resistance? If any of those 6 factors are in play, spontaneous healing is highly unlikely, and you're eventually going to need definitive surgical reconstruction. Similarly, if someone presents with a stable, adhesive small bowel obstruction, we follow a very strict clinical roadmap. At 0 hours, we start with non-operative management, an NG tube to decompress, bowel rest, and IV fluids. And honestly, this works in up to 70 to 80% of cases. We observe them closely for 24 to 72 hours. But if it doesn't resolve in that window, no flatus, or the NG output is still super high, surgical exploration becomes completely necessary to prevent delayed bowel ischemia. All right, Section 3, Meckel's diverticulum. This is a fascinating congenital anomaly. Context is literally everything with this one. Imagine a 19-year-old comes in with sudden peritonitis and you find a perforated Meckel's. That symptomatic case demands immediate surgical resection, either a diverticulectomy or a limited segmental resection. You have to remove the pouch and the adjacent ileal tissue that's been ulcerated by ectopic acid. But on the flip side, what if you incidentally find a perfectly healthy-looking Meckel's during a routine colonoscopy on an asymptomatic adult? You leave it entirely alone. The lifetime risk of a complication in adults is less than 4%, so the morbidity of an elective surgery completely outweighs any preventative benefit. Moving right along to Section 4, short bowel syndrome. Let's look at the systemic fallout of massive intestinal resections. The operational definition here is startlingly simple, but devastating. A normal adult has somewhere around 400 to 600 centimeters of small intestine. When a patient drops below roughly 200 centimeters of functional gut, maybe due to a massive mesenteric disaster, they cross a critical threshold. They simply lose the surface area needed to absorb nutrients and fluids on their own, and usually become totally reliant on specialized support like TPN. But as life-saving as TPN is, it comes with a major hidden cost. Imagine your patient has been on long-term TPN via a central line for months. Because of this continuous intravenous bleeding and a total lack of actual food going through the gut, what classic hepatobiliary complication is almost certainly going to develop? It's all about TPN-associated cholestasis, biliary sludge, and gallstones. Think about the physiology. Because the patient isn't eating fats enterally, the duodenum never gets the signal to release cholecystokinin, or CCK. No CCK means the gallbladder just sits there. It suffers from severe hypomotility. The bile stagnates, forming sludge, then stones, and eventually cholestasis. It's a really profound reminder of how deeply interconnected the gut-liver axis is. And finally, Section 5, small bowel tumors. Time to step into the oncology ward. You absolutely have to know your specific markers for staging these tumors. Take gastrointestinal stromal tumors, or GISTs. Over 90% of them carry a mutation overexpressing the CD117 protein. That is a game changer because it makes them highly vulnerable to targeted therapies like imatinib. Meanwhile, neuroendocrine carcinoid tumors require a gallium-68 DOTAT PET CT scan. This scan uses a radio-labeled analog that binds directly to somatostatin receptors, giving you unparalleled sensitivity for hunting down metastases. Picture this scenario in the OR. A 62-year-old female presents with a bulky primary malignancy in the mid-ileum causing a complete mechanical obstruction. You get in there, evaluate it, and realize it's anatomically unresectable. It has completely encased the main trunk of the superior mesenteric artery. A wide resection here would cause catastrophic vascular injury. So how do you manage your obstruction? In a locally advanced, fixed situation like this, you have to pivot. You shift your goal entirely from cure to palliation. The right move is a palliative surgical bypass, like an enteroenterostomy. You're basically creating a detour, reconnecting the healthy proximal bowel to the healthy distal bowel, skipping right over the tumor. It safely relieves the obstruction and restores that oral pathway without risking a life-threatening dissection. Now, on the flip side, if the adenocarcinoma is resectable, the gold standard for a cure demands 3 incredibly strict surgical steps. 1. A wide anatomical segmental resection of the bowel loop. 2. An en-bloc clearance of the corresponding fan-shaped mesenteric lymph node basin to clear out those regional lymphatics. And 3. Verifying you have achieved perfectly clear negative R0 surgical margins. You can't leave anything to chance. So, what does this all mean? From those deep, transmural skip lesions and Crohn's to tracking down specific molecular markers for GISTs, treating the small bowel is like a giant puzzle. It's never just about memorizing protocols. You have to master the why behind the what. You've got the foundational clinical pearls now, but the real question is, when the unpredictable reality of human anatomy is right in front of you on the operating table, will you have the instinct to know when to cut and when to step back? Keep these lessons in mind and you'll be ready for sure. Thanks so much for joining me for this explainer.